Very pleased to now introduce our next guest speaker, Dr. Jane Estell. Jane has worked at the Westmead, Blacktown, Liverpool and Bankstown hospitals before joining the Concord Hospital Haematology team in 2004, where she still works. There's a few Concord people here. She has a strong interest in clinical research and has been the principal investigator in studies in tissue banking, lymphoma and myeloma, including the pivotal PRIMA study for follicular lymphoma, and establishing the rituximab maintenance. She has numerous publications in international medical journals, and Dr. Estell now runs the myeloma clinical trial portfolio and the incoming director of clinical research at Concord Cancer Centre. Excellent.
Oh my God, I've got to get a photo.
So please come up here. We're talking about aggressive lymphomas and some of the subtypes. Thank you, Jane.
Thank you. That was a little surprise for Professor Trotman because she asked me to be director of the clinical research unit and I hadn't given her an answer, so it was in my bio. That's a hard act to follow, isn't it, following Steve? I've shed a little tear already and yeah, that's a hard road. Before I start, I know you've been asked if you want to do a 5-minute film, and I know some are shy, so to try and get rid of a little bit of shyness, can people call out to me what diseases they or their family have, just so if I'm talking about things I can direct it a little bit? What have we got in the room? I know we've got some Waldenstrom's. Richter syndrome, yeah, great. Follicular, yep.
Grade 3 follicular, stage 4 diagnosis, my husband.
Follicular, great, yep. Diffuse large B cell, great. This lady here?
Stage 4 mantle cell.
Mantle cell, fantastic, yep.
Stage 4
Nodal, yep. Marginal cell, okay, yep.
Peripheral T cell.
Peripheral T cell, fantastic, okay. What was that one?
There you go, you got to do the
CLL, okay.
Okay.
do it all, okay. No, that's good. It just helps me direct things as I talk. Now, my topic today is aggressive lymphoma. So for some of you, I will not quite get to the disease that you have the most interest in. But as you will know, there's lots of lymphomas and each has its own nuances, its own prognosis, its own treatment. And so it's hard to get through it all, but I think you'll take away some bits, and maybe the thing that you get out of this talk is what questions to ask. And quite often I find you probably get more from the other people in the room than from the speakers out the front, but we'll see. Okay, so I think you all know what lymphoma is. Sometimes people are new to this, and sorry to the microphone man for hitting the microphone. But it's a cancer of lymphoid tissue, and it involves the lymph nodes, but it can involve the bone marrow and the spleen. And because lymphocytes, which are the cells that it comes from, are one of the main cells in our immune system, they're designed to travel around the body. So really, lymphoma can occur anywhere in the body because the cells that become cancerous are designed to be mobile. They're in our bloodstream, they go to all of our tissues to protect us from infection, and if they become cancerous, they can also move to all parts of the body. So now my little circle has slipped up there. It's not supposed to be on rectum. It's supposed to be on non-Hodgkin's lymphoma. But lymphoma altogether is 4% of all cancers. About 4,000 Australians are diagnosed each year. It's increasing in incidence. I saw some figures last night that were emailed to me, some little sort of to be released government figures that show that non-Hodgkin's lymphoma is increasing in incidence, but really nicely the cure rate is, the number of people cured is increasing as well, and survival is increasing. So we're on our way to doing a good job, and we need to continue to do a better job for everyone with lymphoma. And a little bit more common in men, but you can see in the top 10 cancers there, non-Hodgkin's lymphoma certainly features. Now, how does it present? You all have your own story with regard to this, but it might be lymph nodes that you notice, it might be shortness of breath, it might be tummy pain, like Steve. It might be that you've had a scan for something else and they found some enlarged lymph glands on the scan that you weren't expecting and you felt perfectly well. Like Steve, you may have had weight loss, fever, sweats, or very, very rarely abnormal blood findings. But lymphoma, leukemia is more commonly found and obvious in the blood, but some forms like mantle cell can be found in the blood. All right, how's it diagnosed? I guess you will all have had some experience of this, and each person's experience is different, but it's a biopsy of some kind, often a lymph node, but it can be biopsy of other tissue depending on where the lymphoma is, and it can either be a surgical biopsy or a core biopsy. These are the main ways that we diagnose lymphoma because we need a piece of tissue. Now, for those who have follicular lymphoma, I don't have a pointer, but the very top square there with those circular looking bits in the tissue, that's follicular lymphoma, and those circular areas are called follicles, and that's why it's called follicular lymphoma. So it's very important that we get a piece of tissue, not just a fine needle with a few cells like they might do in breast cancer or some of the other cancers. So if you're wondering why you had to have a lymph node taken out or a core biopsy, it's because the structure of the tissue is very important. Of course, we get blood tests, bone marrow biopsies, might have CT scans or PET scans, might have lumbar punctures or gastroscopies or colonoscopies. It all depends where the lymphoma is and what needs to be done to get the diagnosis for you. Now, genetics is becoming more and more important in lymphoma, and for some forms of lymphoma, like Burkitt lymphoma, which is a very rare but very aggressive lymphoma, the gene mutation or the genetic abnormality actually is what gets the diagnosis. So a very important part of our testing. But we're also doing mutation testing for other subtypes now, including diffuse large B-cell, which is one of the more common ones, and we're starting to find different subtypes of these lymphomas, which at the moment is not instructing us in terms of what treatments we use, but is getting closer and closer with the clinical trials that we're doing in all of these different subtypes of lymphoma. And so this will become increasingly common. Lymphoma prognosis. To determine prognosis, we look at pathological grade. So this is more important in pathological grade. What the pathologist sees down the microscope and how they grade it is more important for the low-grade lymphomas, particularly things like follicular lymphoma. But the stage, how many numbers of lymph nodes and how far it's spread in the body is more important to most. Different blood levels give us indication of how severe the disease is, whether it's spread to other tissues outside the glands, for example the brain and around the spinal cord, confers a poorer prognosis and requires special treatment. Age, how well you can tolerate treatments that might be needed for control of the disease, but also we do know that the genetics in some diseases is slightly different in older people, and it's the poor genetics of the actual lymphoma in older people that gives a worse prognosis, nothing to do with their particular age or us being ageist about their treatment. And performance status, how well you are, if you're like Steve and you're riding bikes between Sydney or Canberra, or whether, or if you're a couch potato who hasn't done anything for years, and maybe heart and lungs aren't doing so well, then all of that combines to determine how things go to some extent. And clinical staging is determined, and I want to get through to the other disease types, but obviously we have a look and we see if it's stage 1, which is more unusual, through to stage 4. Okay, now what am I going to discuss today? This gets very hard. What's the definition of aggressive lymphoma? That's not straightforward either. So this is a little list. This is off the Lymphoma Australia website. No, actually I forgot to say at the beginning, thank you very much for inviting me here today, Lymphoma Australia, and the ALLG, which I'm an active member of. So this is off the Lymphoma Australia website. Now the top two, so this is divided into B-cell lymphomas and T-cell lymphomas, two major types. There's different ways we can, and this is non-Hodgkin's lymphoma. The top ones that I've bracketed there are called lymphoblastic leukemia lymphoma. They're quite rare. They're treated much more like leukemia, so I'm not going to talk about those today. And I noticed there wasn't anyone in the room that particularly said they had that, but I'm just going to leave those aside because they're really quite differently treated. So lymphoma classification. If you feel you're confused about lymphoma and what type you've got, Don't worry, most doctors are too, except for haematologists who work in this area, because there's over 80 different types. And that's really important when you're online and you're Googling and you're talking to other patients, that what they have and what you have may be completely different, and it's really important that you take that into perspective. So in terms of what we're going to talk about today, I'm leaving out Hodgkin lymphoma. Okay, so that's the top left corner. The other two boxes are non-Hodgkin lymphoma, and I've divided them into B cell on the far side and T cell on this side. I'm going to talk a little bit about T cell. I'm going to talk about diffuse large B cell mainly because it's the most common. Mantle cell I'll mention, mediastinal large cell I'll mention, and Burkitt lymphoma I'll mention. And we can deal with questions at the end about anything else. Okay, so lots of slides on classification because most people find this really confusing, but again, that's just dividing down what I'm going to be talking about. I'm not going to talk about indolent and follicular lymphomas today, and I apologise because there's some in the room and I've got circles coming up. All right, and I've said that to you. Okay, so just to get an idea of the non-Hodgkin's lymphomas, diffuse large B cell over the other side is about 30% of all lymphomas. When we're talking about mantle cell that Steve had, 6%, a rarer lymphoma. Mediastinal large B cells, very rare, 2%, and this is of lymphomas, so getting a rare disease and rare subtypes. Burkitt lymphoma, 2%, and peripheral T cell lymphoma, about 7%. Okay, so why do we divide them into indolent and aggressive? This is a slide I have from another talk. The main difference between aggressive and indolent is the way we need to treat them. An aggressive lymphoma usually needs aggressive treatment. And for many of the aggressive lymphomas, we're really aiming with that first treatment to cure it, to really knock it on the head. Now, that doesn't mean we can cure it. Like Steve, with his mantle cell took, to an allogeneic transplant to get rid of that. But that's the aim for a lot of the aggressive lymphomas. For the indolent lymphomas, we tend to control the disease and give long remissions, get it into remission, have long remissions, but understand that it might relapse or it will relapse at a later date, and we deal with that. We're getting closer to cure for all of these, but we've got a little bit of work to do. Okay, making decisions. It depends on the lymphoma, it depends on the patient, and then we get the physicians, the surgeons, if we need them, the radiation oncologists, our clinical nurse consultants and specialists who are very, very skilled at what they do, and together we bring everyone together to work on treatment for the patient. Okay, this is one of Professor Trotman's little cartoons. We've found a mass, and the good news is we have weapons of mass destruction, and I'm sure that's what Steve felt like when he was going through his chemotherapy, and some of you might be feeling that way too. Okay, so diffuse large B cell. This is a pathology slide of diffuse large B cell, and just to get me into it, it's 30% of adult lymphomas. It's 90% of all of the aggressive lymphomas. It's advanced stage in 75% of patients. So when you're told you're grade 3 or grade 4, you're not alone. The majority of people will be in the same situation as you. It's not common for diffuse large B cell to present as stage 1 or stage 2. So you're not alone in that, and the vast majority of patients that we treat are in the same boat there. Extranodal disease, about 30% of patients have disease that's outside the lymph nodes, and it could be in any organ of the body. They might have B symptoms, so this is what doctors call those symptoms that Steve was talking about: weight loss, night sweats, fevers that can't be explained. The bone marrow will be involved in 20% of patients, but it is curable with multi-agent immunochemotherapy. And so when we meet someone with diffuse large B cell, that is our goal of treatment, is to knock it on the head, get rid of it, first time forever. Now, we do look at, and particularly in clinical trials, we do look at prognosis, And there are ways of us, to some extent, calculating prognosis, but this is not something we can apply to the individual. This is something that doctors look at to see which group of people the patient might fall into, whether they've got a higher risk of relapsing or not responding to treatment, or whether they've got a really good chance of doing very well with treatment. And the acronym down the side is APPLES with 1P, age, performance status. I've put performance status, a little diagram on the other side of the slide there. It's basically how much you're up and about and doing things during the day. LDH level is a blood test, whether the lymphoma has gone outside the lymph glands, and stage is how many lymph node groups are involved and whether it's both sides of the diaphragm. And we do have, for people younger than 60, an age-adjusted score. And this is often worked out by your doctor. It doesn't always tell us what treatment to give, but it might give us an idea to look a bit closely if you score very highly, so that we can make sure that we're really getting it under control and we're really going for cure first time. It would be lovely to have a chart like this that says, this, now IPI is that International Prognostic Index that I had on the slide before. You know, this is where people fall with their disease, and there's a perfect treatment for each one of those groups. It would be lovely to have that, and we're working toward that, but we're not quite there yet. But that would be the goal. So what are the challenges? Should we treat all diffuse large B-cell non-Hodgkin lymphoma the same? By the way, medical people use lots of abbreviations. If I throw one in a slide that you don't understand, please just yell out and go, what is that? Because they're long names often and I can't fit them all on the slide. So DLBCL is diffuse large B-cell, the type we're talking about. Should we treat them all the same? Well, we know that this is a group of diseases that, even though it's called diffuse large B-cell, your lymphoma is as individual as you are. It may have lots of things in common with everybody else's diffuse large B-cell, but it's not exactly the same. And we're learning more and more, particularly with genetics, about how to divide these up and how to cater to treatment, and that's where medicine's going. The patient population's a very heterogeneous group. We've got the very, very elderly and the very, very young in lymphoma. So it may be that treatments and the side effects may be tolerable for a younger person and not so tolerable for an older person. It may be that there's two older people, one is super fit and running marathons and they do okay, and the other one has health problems, heart, lung, etc., and may not be able to have some of the medications. So we have to tailor it to the patient. And as I said before, we have new genetic insights, and I'll just start. Now, this is the type of thing. Don't be bamboozled by the science here. This is really just to, I guess, give you hope that we are looking at all of these really interesting scientific areas. So for diffuse large B-cell, we now can divide based on the pathology staining. And staining and genetics, we can now divide them up into groups called GCB and ABC. And it just is where that cell originally came from in the system, which cell in the body originally became cancerous. And we know that the GCB group, they're actually still quite a mixed genetic group, but they generally have a better prognosis than the ABC group. The ABC group don't do as well with our current treatments, and they have particular genetic pathways that enable us to look at targeting those pathways for future therapies. And there's clinical trials underway specifically targeting people with the ABC type. So there is hope going forward that we'll be able to tailor these treatments to individuals' tumours. Then in more recent years, we've had a disease called double hit lymphoma, which we identify, and it's identified by genetics on the lymph node biopsy, and it accounts for about 5 to 10% of people. It's actually the GCB type, and for years and years, right back to when I was a registrar and even a resident, I remember people who had diffuse large B-cell who I thought, oh, they're going to be cured, they'll have their chemotherapy, they're going to be cured. And they didn't. And I remember one young man in his 20s who nothing touched his, and this is 30 years ago, mind you, everyone, nothing touched his diffuse large B cell, and he just got sicker and sicker, never got into a remission and passed away. And I was devastated at the time, and I couldn't understand why. In those days, we didn't have this technology, and we didn't understand that there's a small group of people that have these two genetic abnormalities that, when combined together, make them very resistant to disease. And this is an area of much research. Along with double hit, we also have a group called double expressor, and this is looking at the same genes, but actually, rather than doing the genetic test, just looking at how the biopsy stains when we put special stains on it in the laboratory. And we know both of those groups don't do as well as the rest of the people with diffuse large B cell, and we're starting to work on treatments for those areas. So it's exciting that we're starting to understand that there's a group of people that may not respond as well to treatment, but that we can keep working on finding better treatments for them. So there's a lot of nuances in the treatment of any lymphoma. Diffuse large B cell, generally rituximab, the R. So each letter of R-CHOP stands for a drug. So rituximab, cyclophosphamide, doxorubicin, vincristine and prednisone have been the gold standard for treatment of diffuse large B cell for many, many years. In fact, all of the time that I've been practicing. Now that might sound a bit devastating because you think, oh, things haven't changed in 30 years. That's a bit devastating. Many, many things have been tried, including far more intensive therapies, far more aggressive therapies, therapies that cause lots of side effects for lots of people. And the bottom line is none of them worked better than this one. So we come back to that. Now, originally, back 30 years ago when I was talking about it, was just the CHOP. And then 20 odd years ago, we got the rituximab, and that made the world of difference to the prognosis. So we have made improvements. CHOP's been there for a long time, rituximab is more recent, and the cure rate went up significantly when we added the rituximab. It's given every 21 days. You can give it every 14 days if you give GCSF injections, but it doesn't necessarily work any better giving it every 14 days, but some people prefer just to get the chemotherapy over and done with. Particularly if you're younger and you can tolerate it every 14 days, it just gets the treatment over more quickly, and some people request that just to get back to life, work, families. So 75 to 80% of patients will be free of their lymphoma after 6 cycles of their therapy. Okay, there are side effects, and this is just a general list of side effects looking at R-CHOP. People with the infusion may get an infusion reaction, particularly the first time they have rituximab, low blood counts, hair loss, nausea and vomiting, which we can control very well, and you should not have any nausea and vomiting, should be got under control in the first cycle. Do not be afraid to say to your doctor, my stomach does a somersault every time I look at food. Get onto that as quickly as possible in your first cycle of chemotherapy, because if you get onto it the first cycle, you'll go through things really well. Don't let that get out of hand. Tell us if you've got pins and needles. Heart we look at and check, and steroid side effects, hunger, sleeplessness, high sugars, moodiness. You've got an excuse for moodiness if you're on steroids, and heartburn. Okay. You will have a scan at some point during your treatment. Now, it depends a little bit on the scans available in your area, and it also depends a little bit on the protocol that your doctor's using, but you usually have a scan after 3 or 4 cycles of treatment to make sure that you're responding. We want to see it melt away with diffuse large B cell, and if it's not melting away, or particularly if it's growing, then we need to change treatments. This is quite different to follicular lymphoma. I know there's some follicular lymphoma in the room. It doesn't have to be completely gone with follicular lymphoma, but for diffuse large B cell, we like it to be gone. And this is an example of a PET scan. This is an American slide. We don't do PET scans this often in Australia. You don't need all that radiation. It doesn't give you any extra benefit, but this is a person with all this black stuff, is for the most part lymph nodes, and the second to the disease has gone away. The black dots you see, the top is is the brain, the middle one is the heart, the little dots lower than that is the kidneys, and the bottom one is the bladder. That is all normal. You're allowed to have that. That's the dye going through your system, okay? But all the lymph glands are gone away. Okay, just terminology. Refractory disease means it's not being affected by the treatment. It's staying there. Stable disease is it's staying the same. Partial response means the lymph glands have actually gone down by more than 50% of their volume, but they're still slightly enlarged. Complete remission is we just can't see it anymore. It's gone. And the question I often get is, when am I cured? Time will tell. Okay. We can't necessarily say at the beginning. All right. Modifications or alternatives. Some of you might be sitting there thinking, oh, I didn't just get that. I started on cortisone and prednisone. So for some people who have very bulky disease and who have lots of symptoms, before you actually start the chemotherapy, and this goes for any disease type, not just diffuse large B-cell, particularly the aggressive lymphomas, you might be given 5-7 days or even just a few days of high-dose prednisone. That's just to calm the symptoms down while we're getting everything ready to start treatment. But that needs to be done after you've had all your biopsies and your diagnostic material. For people who are over 80, or for people who have other health problems that mean that full-dose chemotherapy is not possible, we can give R-mini-CHOP, which is a lower dose. Now, some of you might say, oh, I've been treated with, RACVBP. Now, this is one of the alternative treatments, and there are many like this. I've just chosen this particular one, which the French invented and used, which seemed to show some benefit in younger patients. And it is and at the time it was compared to R-CHOP. There were some problems with this study in that the R-CHOP people didn't do as well as they should have compared to other studies, so they wondered if there was a bit of a problem with the study. So this treatment hasn't been taken on board by everyone, and I've used it, but it is used by some people. It does have more side effects than R-CHOP, and so for some people we will think about it if they've got a higher grade or higher stage disease, higher prognostic index, if we want more intensive therapy. But that's quite individual. So don't be concerned if you're not getting R-CHOP. A lot of the drugs are the same. It's just the way we give them is slightly different. So just be reassured that it's not necessarily the wrong thing to do. R-dose adjusted EPOC or EPOC-R is similar drugs, it's just given in a different way. So this is for double hit, for example, this is more commonly given than R-CHOP. Okay, so I'm going to run through. Now, because the cure rate of diffuse large B-cell is very good, there's not too many clinical trials being done in newly diagnosed people, but we do know those ABC type people don't do as well, and the double hit people don't do as well. So this is where a lot of the clinical trials in newly diagnosed diffuse large B-cell are targeting to try and get better treatments for these people. And there's a Polarix study at the moment for people who've got a high index with R-CHOP plus a new drug called polatuzumab, which is an antibody with a little chemo attached to it so that it targets the chemotherapy to the actual lymphoma. So all exciting stuff. I've said that. I'm going to just skip over in the interest of time. Post-treatment, you'll have regular visits with your haematologist, as Steve said. You'll have scans every now and again. With diffuse large B-cell, you'll have them during treatment and straight after treatment, and then maybe at 6, 12 and 24 months. This is quite individual. It's not set in stone. In Australia particularly, we have tried to move away from doing too much scanning. We don't want all that radiation. If you're cured, we want you to go on and live a long life and not get a second cancer because of all the radiation we give you, but we do need to do some at the beginning to make sure we're on track to cure. Unfortunately, relapses do occur, and it depends a little bit on your prognostic index as to whether relapse is more or less likely. And if they do occur, they tend to occur in that first 2 years after treatment. After that, it's much rarer, so we watch you more closely for the first 2 years. Now, if the disease doesn't go away, or in the PET scan where the arrow is, the disease is growing through treatment, we will consider high-dose chemotherapy and autologous stem cell transplant. And Dr. Hamad is here, and she's going to talk about that after me. And we will look at other therapies depending on the type of diffuse large B cell. All right. I'm going to skip over that. I've got a lot of slides and I'm running out of time. So, just to say, at relapse, when people with diffuse large B cell relapse, that's when we've really got to do some hard work and get the best treatment for them. And there are many new drugs. All of these boxes here are new drugs and the new ways that drugs work. And a lot of these are in clinical trials and we have experience with them. So to give you an idea, this is the number of clinical trials going on in New South Wales, this isn't even in Australia, for people with relapsed diffuse large B-cell lymphoma. Some of them dependent on the type, but these are all new drugs that work very, very well, we hope, but that's why the studies are being done. But many of them have been trialled overseas already, and we know that they have good activity. Because drugs are funded by the PBS in Australia, we need better data comparing them to our standard treatments, and so we often get drugs that already have proven effects here, proven effects in studies overseas, and they come to us a little bit later, and so we know that they're going to work. We just need more data to get the government to pay for them. Okay, I'm going to skip over this one. Primary mediastinal lymphoma occurs in younger women. It's also treated by R-CHOP chemotherapy or similar treatment and is highly curable. I'm going to skip over that. Highly aggressive Burkitt lymphoma is probably one of the most aggressive lymphomas. It tends to occur up near the stomach. It tends to occur in middle-aged men in Western society. It's different in Africa, where it happens in children. It's very aggressive. Patients often come very, very sick. It has a particular genetic and it has a particular high-intensity treatment. Mantle cell. So, as this is the disease Steve was treated for, 70% have advanced stage, 75% are males. He was younger than most, 30% have B symptoms, and the standard treatment is has been in the past CHOP, but we are getting more and more treatments, including bendamustine, which is rituximab and bendamustine, another chemotherapy. Don't worry about all these names, just know that there are alternative treatments. And one of the new treatments that we've had over the last few years is called ibrutinib, and ibrutinib thankfully has been listed on the PBS for people with relapsed mantle cell lymphoma. The fantastic thing about ibrutinib is it's a tablet. It's a targeted therapy, it's not a chemotherapy. You're at home, taking a tablet, getting on with life. So, and this is being trialled in many other forms of lymphoma. Okay, quick trip through peripheral T-cell lymphomas. They are a very different, they're a very rare group of lymphomas, and they all differ from each other. There's 15 different subtypes, and it accounts for less than 15% of lymphoma. So each individual type of T-cell lymphoma is very rare. It does have a worse prognosis than DLBCL, and it's very easy to get overwhelmed with all of these lymphomas, and it's important that you talk to your doctor, find out which one you have exactly, and just take general hints from this. Now, this is a graph that shows, the red arrow shows the improvements in treatments in B-cell lymphomas over the last few years, and we've had improvements in T-cell lymphomas as well, but not as much as we need and not as much as we want. And so we need to keep working on this area, and we are in terms of clinical trials. Now, we do use CHOP in T-cell lymphomas. Now, we don't use the R because rituximab, the R that we used for diffuse large B-cell, targets CD20, and that's only on B cells, it's not on T cells, so they don't get the rituximab. And etoposide is a drug that's often added into CHOP to assist. Now, this is a medical table. Don't take too much interest in what's happening over the other side there, but this is some of the drugs that we're using in T-cell lymphoma that are being trialled, and there are many, many more. So if you have T-cell lymphoma, you will probably be exposed to these types of names, and brentuximab particularly is targeted toward T-cell lymphoma and Hodgkin's lymphoma, which I'm not talking about today, and is offering great hope for people in this area. This is brentuximab. It targets an antibody, it targets a surface protein, a little bit like rituximab does, but it's the one that's on T cells. Now, this is a medical slide again, which is very hard for people who are not medical to understand, but the most important thing is in this trial, I'm going to walk away from the microphone a bit, this graph up here, if the lines, coloured lines go down, it means the patients did well, they responded to treatment. It means that's the size of their lymph nodes falling. So you can see in this particular trial of 57 patients, all but one responded to this treatment. Some better, some worse. But it's a very exciting treatment that's in trials and becoming available as well. And it has improved the survival of people with T-cell lymphoma. Other drugs, pembrolizumab, this is a drug that's used in melanoma and lung cancer and many other cancers, and it's been shown to be effective in some forms of T-cell lymphoma. And drugs that we use traditionally for leukemia are now being trialled in T-cell lymphoma and getting some effect. So we're starting to learn that a lot of the drugs that we're using for other diseases actually might work for lymphomas and vice versa. So we're starting to trial across these areas. I just wanted to point out there is a trial called the Estell trial, which is run out of Monash in Melbourne and Concord for people with T-cell lymphoma who are relapsed. And that's always a good option. So research is moving us away from blunderbuss chemotherapy and getting us to more targeted chemotherapies. And some of the newer drugs are there that you might come across in your lymphoma walk. And just to say that it does take time for us to get drugs through the clinical trial process and development. But a lot of this has been happening for the last 10 and 15 years and longer. So you will be reaping the benefits of all of this research that's happened over the last few years. I also want to let you know about ClinTrial Refer app. This is an app that is available to doctors and patients. This is New South Wales specific one, but there's one for every state that actually it's free. You can download it. ClinTrial Refer is the name, and it shows you what the clinical trials are for each disease and where that trial is happening, and we encourage our patients to use that. So thank you for listening. Thank you to Lymphoma Australia and ALLG for putting on a great day like this. Thanks to my patients who teach me so much, to my colleagues at Concord who've helped me with a lot of these slides, and I need faster internet speed to keep up with all you guys. Thanks.
Thank you.
Is there any questions? Oh, you're in the wrong one. Thanks, Jane. That was a fantastic presentation. It just shows that, like we mentioned before, that even two patients with, say, diffuse/B-cell lymphoma, quite often your friend might have completely different treatments, and it's really important to make sure you know what exactly your treatment is, and speaking to your haematologist is really, really important.
Lots of questions.
Yeah.
Keep asking questions.
It's so confusing even for health professionals, because as the years go by, we're finding more and more subtypes of even, say, diffuse/B-cell lymphoma. I'm using an example, but we're finding more and more genetic mutations, and everyone's completely different. So yeah, is there any questions for Jane? Just a couple of quick ones while she's still here. Yeah.
So the double hit and double expressor types, do the patients with those types have a greater incidence of actually having extranodal or stage 4 lymphoma? Does it sort of go hand in glove with those types?
Not necessarily. It's about the same as others with lymphoma, but it's just that the treatments don't quite work as well, and we need to look at novel treatments, which is the clinical trials. Yeah. Yes?
How is the treatment of Richter's
Richter's. I didn't cover Richter's, which is a very good thought. Yeah, so it is actually treated a lot like diffuse large B-cell lymphoma, because it is actually, Richter's transformation is usually a diffuse large B-cell. So it depends on the age of the person and what other treatments they're having for the disease that it's transformed from. But yeah, it's usually treated like a diffuse large B-cell.
It's not a plus, like a double whammy on that.
It's usually the cells from the original disease, whether it was CLL or CLL's the most common, is transformed, has mutated, and so those people who have that usually have some kind of, which we don't understand, predisposition to forming lymphoid malignancies. So they're related, yeah.
So you mentioned about the cell of origin.
Yeah.
I was told that they can't do the blood test. They do those blood tests in America, but not here because they won't pay for them.
Yeah, cell of origin is done on the biopsy tissue. And it's at the moment, it depends how you do it. There's a number of ways of doing it. You can do it as just a stain on the biopsy, which we can do here, and any pathology department can do here. There's another way of doing it, which is genetic sequencing, and that's a research tool only. That will become more and more available, but at the moment we don't really know how to use that information, so it's best to actually do that as part of a clinical trial. Yeah, but we can do it basically just on stains in the pathology slides. Yeah. Was there another question? Yeah.
Just a question on a specific side effect from cyclophosphamide.
Yeah.
Do you see, or have you seen many patients that have developed interstitial cystitis from cyclophosphamide?
I probably have. It's not terribly common. Obviously, one of the side effects we worry about is the hemorrhagic cystitis of the bladder, which is why nurses and doctors give you lots and lots of fluid when you're having cyclophosphamide and ask you to empty your bladder quite regularly so that you don't get damage to the bladder there. But yeah.
Pretty good at treating that.
Worse than chemo, I think.
Yeah, we actually, the idea is to prevent those diseases, and all of the work that the nurses do in giving lots of fluid before the chemotherapy, all the anti-nausea medications, it's all to prevent the side effects, and we hope we're not seeing those. Yeah.
Much better these days.
Yeah.